educative video of exoscopic microsurgical management of large right frontal insular temporal frontal opercular glioma. This 64-year gentleman presented with seizures, post-seizure weakness of left side limbs. Examination showed glaucoma score 15, left hemiparesis 3/5. With this, he was investigated with the MRI scan brain, MR angiography, showed a large right insular frontal temporal opercular glioma with edema and mass effect on external capsule, internal capsule, caudate nucleus, and the ventricle on the right side with a significant amount of edema and midline shift from right to left. These are the various sections of MRI scan showing the location, extent, and involvement of the tumor with areas of necrosis suggestive of a high-grade tumor. With this, he was taken up for surgery, underwent right frontotemporal pterional craniotomy, transsulcal exoscopic microsurgical approach, total removal of the glioma. These are the plans of craniotomy. Craniotomy is planned frontotemporal region along on the coronal suture because the tumor is across the coronal suture, half in the front, half behind. The pedicle flap is raised on the superficial temporal artery. Now, once the dura mater is opened with the base towards the temporal region, the cerebral cortex, the frontal lobe is exposed. And in these cases, we prefer to access these tumors through the sulcus. And you can see there is a widening of the sulcus and widening of the gyri, suggestive of the location of the tumor on the surface. These are the points one we should look for when you're operating these lesions, which are situated in the vital areas. Widening of the gyri, paleness of the gyri or redness of the gyri, change in the gyri suggest the underlying situation of the tumor. Now the sulcus is opened about 1 to 1.5 inches and deepened. In this case, the tumor is skirting around the coronal suture. Our craniotomy should be on the coronal suture, half anterior and half posterior. And we should access this tumor anterior to coronal suture, which is of great importance where we can prevent the motor area, and from anterior to posterior we can go in the tumor, and it helps in preservation and not injuring the corticospinal tract and the motor areas. Now the sulcus is deepened about at the depth of about 1 to 1.5 centimeters. We encounter the tumor, which is necrotic and vascular and ill-defined, creamish, yellowish in nature. With high illumination and high magnification, the debulking of the tumor is started. At every stage of debulking and dissection of the tumor, we must achieve hemostasis. This tumor located at the insular cortex and frontal and temporal opercular regions gets a blood supply medially from the middle cerebral artery, cortical branches, and the lenticulostriates, lateral lenticulostriates, and the insular branches from laterally. Medially, it gets a blood supply from the anterior cerebral artery, the deep cortical branches. Inferiorly, it gets blood supply from the anterior choroidal artery and posterior communicating artery, which supply the deeper parts. And this needs to be understood, and we need to coagulate and achieve the hemostasis at every stage. Now you see, as we keep going deeper and deeper, the necrotic tumor starts appearing, and you can see the tumor with vascularity, the blood vessels coming from the branches as I mentioned to you. Every stage, these vessels need to be coagulated and proceed circumferentially like descending a staircase and or a pyramidal fashion and keep coagulating and debulking the lesion. We prefer always to have hemostasis at every stage so that we don't miss the tumor and normal brain boundaries, because it's very difficult as you go deeper and deeper to separate the tumor and the normal brain. So keeping the field clean helps us to understand this so that we prevent the injury to the normal surrounding brain, vital location like insular cortex, frontal and temporal regions. Now we are going deeper and keep coagulating. And now you see the blood vessels coming into the deeper parts of the tumor. These are the vessels which cause bleeding in the tumor, and you keep coagulating. Always remain in the center of the tumor and go to the periphery. Identify the color of the tumor or the color difference between the tumor and the normal brain and the suckability of the pathology. Usually the gliomas, tumors, metastasis or the lymphomas, they come easily into the suction. The normal brain doesn't come into the suction. The suction and bipolar should be kept low so that we don't inadvertently, with the forceful suction, damage the surrounding normal brain. Now, with high illumination and high magnification, as I mentioned to you earlier, keep achieving hemostasis at every stage and proceed. Now we have reached the deeper part of the tumor. You can see the hemostasis being achieved at every stage and proceed further. This is from all around. We have debulked the tumor and achieving the hemostasis. Then further you go down once you achieve the hemostasis and debulk the tumor subsequently. You see the blood vessels which are very high vascularity and they are all in the tumor bed and they need to be understood and coagulated. This is the absolute hemostasis is achieved and is debulked all the areas, anterior, posterior, medial, lateral, and inferior. Here appears to be the temporal region towards the insular cortex. There appears to be some tumor, again, that is decompressed, debulked, till we get the normal brain and the hemostasis is achieved, as I mentioned to you earlier. Now, slow under high illumination and high magnification and debulking, achieving the hemostasis, understanding the boundary between the tumor and the brain is of utmost importance in this, and understanding that the normal brain is difficult to suck, whereas a tumor easily comes into suction. That fact needs to be kept in mind in the deeper planes. Now you see the posterior and inferior part of the tumor is debulked and hemostasis is achieved. Here we feel we have reached the complete periphery of the tumor where there is a normal brain is seen, and we decide to stop at that after achieving the hemostasis. At this stage, we ask the anesthetist to raise the blood pressure 30 to 40 millimeters more than the induction blood pressure. Wait for about 10 to 15 minutes so that we confirm the bleeding at the tumor bed, which is of utmost importance in cases like this large vascular necrotic tumor. Sometimes during the dissection, the blood vessels retract to the brain parenchyma. Post-operatively, due to the increase in the blood pressure, they start bleeding and cause post-operative hemorrhage. This fact needs to be kept in mind, and accordingly, we need to increase the blood pressure before we decide to close. That's the deeper parts of the tumor glioma, which is there's some amount of ooze from the deeper vessels that is coming probably from the insular branches of the middle cerebral artery. They are coagulated patiently and achieved complete blocking or hemostasis as shown here. Now there appears to be again at the deeper parts, some amount of tumor is there, again debulked and coagulated and hemostasis is achieved. Here it's very difficult to say that we have taken out 100% of the tumor, but what it appears to us it needs to be done. Here we can use the fluorescein angiofluorescein or dye to confirm this, and you can have much more excision in these cases by using these fluorescein techniques. Now the deeper part of the tumor is taken out completely, anterior, posterior, medial, lateral completely removed, and hemostasis is achieved. Sometimes we need a Surgicel, and coagulating on the Surgicel is of great help. It sticks to the tissue and prevents the slow oozes from the capillaries of the small vessels. This technique we keep following for almost 2 decades, and it's of great help we do that. So all around the Surgicel is placed because tumor is quite large and vascular and necrotic. There are always the chances of post-operative bleeding. One needs to be kept in mind. And absolute hemostasis should be confirmed for minimum 15 to 20 minutes post-excision, and increasing the blood pressure is of utmost safe for the patient and for us, so that you don't need to re-explore. We use the hydrogen cotton in the tumor bed. Again, this helps in stopping the bleeding from the small capillary oozes and helps us in achieving the hemostasis to great extent. Keep it for about 5 to 10 minutes and wash the area with normal saline and confirm the absolute hemostasis. That's the end stage of surgery. Brain is lax and pulsating. You can see the complete excision of the lesion, and brain is lax and pulsating, and the hemostasis is achieved and confirmed completely. Dura mater is brought back and closed with 50 or 60 ethylon, as much watertight as possible, as shown here. Bone flap is replaced and fixed. This is the dural closure, as much watertight as possible, and the 450 or 60 ethylon is good enough with a continuous suturing of the dura mater. Sometimes if the dural loss is there or shrink is there, we use the pericranium as a graft. This is a bone replacement and fixed. Scalp is closed in 2 days. Same day evening, we get a CT scan brain done. Shows complete excision. There is no hemorrhage, edema, swelling. Ventricles are normal. This is his post-operative clinical status on day 2. Glaucoma score 15, no neurological deficits, knowing all 4 limbs very well. This is his on day 5. He goes home without any deficits. Histology is glioma grade 3 astrocytoma. Will go for radiation. Our neuroanesthesia team, treating patient neuro rehab team, our presence online of more than 620 microsurgical, exoscopic, endoscopic, navigation guided, educative neurosurgical operative procedural videos on our neurosurgery video atlas on YouTube. Thank you very much for viewing.